This conference will now be recorded.
Okay, so I see Len, Sierra, Bill Franklin, Jake Hannum, Gary Gunville, Ken Anderson, Sylvester Mann, John Appler, Dana May Louie, and Jay Curran. Did I miss anybody? Okay, that's a good start. So we have nobody new.
Somebody just joined a telephone.
It's Dennis.
Hello, Dennis.
Yeah. I would have guessed in a minute or two. How you doing, Dennis?
Good. How you?
You staying dry up there, Dennis? I got soaked earlier on today.
Yeah, we got pretty heavy rain earlier. Right now the sun is shining.
Oh, we don't have any. Well, get ready for more rain because it ain't shining down here.
Oh, yeah, that's probably, they said we'd get more tonight, tomorrow morning.
Sorry about that. Okay. So there's nobody new, but I think there's some people with some interesting issues that are on the line tonight. So let me go down and just figure out who needs some time, and we'll go from there. Len, do you have anything you'd like to talk about?
Nothing for me, Rick.
Okay.
Nothing, I should say nothing personal. If we have time, we can maybe discuss the switch. If anyone is taking Zytiga, switching from prednisone to dexamethasone.
Mm-hmm. Yeah, I didn't read that yet, but I did see you sent that out. So I'll put a little note by your name, and we'll see how we do with time. We should be good today. Bill, anything for you?
Yeah, I'll run something by you.
Okay. Jake, anything for you?
No.
Gary, anything for you?
Nothing for me, thank you.
Okay. Ken Anderson, you want to talk to us a little bit about your situation?
I'm not sure exactly what I mean, sure I can. Yeah, I can do it.
Okay. See what the guys think. We'll get Sylvester, anything for you?
No, thank you very much.
Okay, John Appler, anything for you?
I'm good, Rick. Thanks a lot.
Okay. Dan and May, anything you'd like to discuss?
Yes, we do.
Okay. Jay Curran, anything for you today?
Yes, change of treatments. Go ahead.
Okay. And Dennis, anything for you today?
No, just listening in.
Okay. So we got 4 people that would like some time, and Len, so we're going to have plenty of time, assuming nobody joins us that's new or anything like that. So we got loads and loads of time today, so we should do just fine.
This is Peter. I'd like to inquire about an email I got today from Walt in California.
Oh yeah, I beg your pardon. I didn't call your name out, and you didn't say anything.
Well, now I am. Yes.
Okay. All right. So Peter, and that's fine. I beg your pardon. I'm so sorry. Okay. So let's kick off with Bill.
Yeah, mine'll be kind of quick. Unfortunately, I find myself in a situation where I'll be having surgery, but nothing to do with prostate cancer. I need shoulder replacement surgery. And the last time I had a bone density scan, it showed basically, it was kind of, he said borderline osteopenia. And it's been a year. I'm going to get another one, but just wondering, is anybody on the call had an experience where they had to do anything with their bones, being on long-term ADT or anything?
Well, I have.
Okay.
So I can talk to you about me, what other people are thinking, but yeah. So I was borderline osteoporotic, not borderline osteopenia, and I took I had 3 infusions of Zometa annually. One right when I started treatment, one at the end of year 1, and one at the end of year 2. And I also changed my exercise regime, and I did improve my bone density very significantly. I haven't had a bone density test in about 5 years. I probably need to get one to check. But I did have a hip replaced earlier this year, and it was pretty bad on one side. I mean, the whole of one side of the ball of the joint was worn flat. So it was significant bone damage, to the extent that it's attributable to the ADT. I really don't know. I did discuss it with the surgeon, and he said there could well be an impact. He said also it could be a result of having, a fair amount of radiation to that area.
Well, I don't think that the problem was attributed to ADT. I was just concerned that the ADT led to my osteopenia. And like I said, it's been a year since I had the last test, and I've been off of ADT for about 14 months now. So I think it'll probably be fine. I was just wondering because the orthopedic surgeon suggested to get another bone density scan just in case before they do the operation. So
yeah, I think sounds like a smart move. But I mean, to the extent that my bones were soft, that may have something to do with the ADT. It may have something to do with the fact that I was osteoporotic before I even started ADT. But I don't know. Anybody else got any input on that?
Well, I do have a question for Bill. Why do they think the osteopenia, is that a problem for your shoulder replacements?
No, it's just that it was the reading I showed him from last time was osteopenia, and there hasn't been a reading. I mean, I haven't had a scan in a year, even though I've been off of ADT. He just thought it would be a good idea to see if it had gotten worse or better. So like Rick said, I've been exercising pretty vigorously for the last year, and been off of ADT. My shoulder problem is from an old injury that I got in the military. I have pretty severe arthritis in my shoulder, and it's the ball joint has several big bone spurs on it, and it's about 70% of the cartilage in my glenoid cup is gone. So,
Bill, did they put you on anything like Prolia or any bone strengthening drugs?
No, I never took any bone strengthening drugs
that's probably the usual only concern.
Yeah.
You're actually on those, like they tell you not to do any dental work if you're on that.
Yeah, that's like before I have surgery, I have to get a dental checkup too. They check for any kind of dental infections or anything before you get any kind of bone surgery. I didn't know that. I'm learning all kinds of wonderful things as I get older. It's great.
Somebody else? Did someone else want to say something to Bill about that?
Well, at least he's getting older.
Yeah, I'm still getting older.
Welcome to the club, Bill.
This is Jay Kern in San Francisco.
Go ahead, Jay.
I don't know how much this will help you, but my doctor has asked me to go on Shiva, and so I have to get the dental approval. But I guess there are some questions about Shiva if you stay on it for a while. But anyway, that's how I know about it.
Well, I'm hoping not to go on any further prostate cancer treatments at all. But
yeah,
I just got my blood test and everything about a little bit over a week ago. Everything was perfect except for the same problem I had before. My testosterone is not coming up. It's still 175. It hasn't budged from the last reading 3 months ago. I feel good. I still exercise vigorously, but it's just not moving for some reason. So
120. I've got a note that it was 125. Is that what you just said?
I said 175. So yeah.
Oh, 170.
Well,
Okay.
it's not much.
Okay.
Yeah, it was 125, I guess, 3 months ago.
Okay. Well, one thing that I did, and after about, I think it was probably after about a year and a half of being off, was I talked to my urologist about supplementing my testosterone, and he thought that would be a good plan. And I tried for a while, but it didn't do me any good. And it was messy.
Yeah, my doc said no. He said he wouldn't want to give me supplemental testosterone for 3 years after the treatment. So, and plus he said if you're feeling okay and you're you can recover and everything, so from exercise and all that, it's not that bad. But I said, yeah, you're not the one going through it, but so.
Do you know what your testosterone was before you ever had any treatment, Bill?
Yeah, it was up around 700 and stuff.
So 175 is pretty low for you then.
Yeah, it was basically, it was down in double digits during treatment.
Bill, it could have been 2 years. I'm saying 18 months. I'm saying that from memory. I'd have to go in and I'd have to look, but I mean, it could easily have been a couple of years. But one thing that I wanted to mention to you was that it was low. I think nowhere near as low as yours. And then I did the treatment. It didn't make any difference at all. I did it for about 9 months. It made no difference. And then I stopped, and then just by itself, it just went back up to around 700, which is where it was before. And that was probably about 4 or 5 years, probably about 4 years after I came off.
Yeah. So, well, he didn't have any, he couldn't give me any reason why. He said they could start looking at other things, thyroid or what's the other one? The other gland that works on that?
Adrenals?
Yeah. No, it wasn't adrenal. It was thyroid and something else, he said. I can't remember. I know the adrenal gland's in there, but anyway, he said we could look at something, but even if they found a problem, he wouldn't want to give me supplemental testosterone. I guess he didn't quote any studies or anything, but he said he doesn't give it to his patients for up to 3 years after treatment. So
okay. Well, listen, if you're feeling good, go with it, and maybe it'll come back of its own. And if it doesn't after another year and a half or so, then you can think about supplementing.
Yeah, the testosterone's not my big issue right now. I'm worried about this. Get this shoulder surgery done and recover from that. So.
Right. Are you considering pitching for a minor league team or something? Or?
No, I don't need to do anything like that.
Oh, okay.
No, I want relief from chronic pain. That's that's my main concern.
I understand that because I know what the hip pain was like for ages before I got it fixed. So all right. Anybody else want to say anything to Bill before we move on?
Well, Bill, when is the surgery scheduled?
I haven't scheduled it yet.
But you are going to do it.
Oh, yeah, I'm gonna do it. I've been on methylprednisolone, steroid dose packs. I've had, cortisone injections, Synvisc injections, but the methylprednisolone,
Prednisone.
methylprednisolone. Yeah, so that gives me that lessens the pain. It's worked pretty good. She's put me on kind of like a cycle of it, my primary care physician, but it doesn't get rid of it by any means. There's days I'm on it where by the end of the day it's aching really bad, and if I don't take it after that cycle wears off, the pain is consistent every day. So I had the consultation today. I have another consultation which I had set up in the past. I'm going to go ahead and keep it with a different surgeon. It's on Thursday, and between one of those two guys is going to do the surgery. I just haven't decided which one. So,
well, of course, the prednisone or prednisolone, both of them, basically the same thing. They in themselves can cause osteoporosis, so you don't want to stay on those too long. So
right.
I'd schedule that surgery ASAP.
My primary care physician had said you can't take these forever because, and not only, she also said it can cause compromise your immune system, make it weaker, and you're more prone to infections or colds, flus, all those kind of things. So,
yep.
Which I don't need any of those either, right?
Hey, listen, with those 10-year-olds running around, it's pretty hard to stay away from them, isn't it?
I know. It started at the very beginning of the school year. They went to school, and them and all their friends came home with a cold. So.
Okay. All right. Paul, I see Paul Frieder's joined us. Paul, do you have anything you'd like to discuss today?
Oh, it was from the last. Oh, I forgot now. I forgot. I actually I wasn't able to make the last meeting, and there was something I wanted to talk about then. But I think it was insurance costs, but I'm not sure. So let's say nothing tonight until I'm sure I know what I want to talk about.
Well, we'll check back with you, and in the meantime, see if you can figure out what it was, and then.
Okay. All right. Thank you very much. Sorry I'm late. I had an online lesson I couldn't get out of.
No worries. No worries. Okay. Ken Anderson, would you want to give the guys an update on your situation and see what they make of it?
Sure. I went in this past week for my monthly, lab work, and lo and behold, 3 days later, I got the news my PSA had taken a step upward from 0.5 to 0.6, and that on its own caused me some grief, I guess. But after talking to my oncologist here locally, and Rick, of course, and Paul Korn, they both said take a chill pill and let everything settle and see where it goes from this point. I did put in a request on the 18th of last month. I had a colonoscopy, and I wanted to know if anyone had, maybe on this call, any experience with a PSA rise based on the colonoscopy itself. Korn said probably was not or would not be related, but he couldn't rule it out. And he also wasn't sure in regards to the PSA test, because the testing organization only uses like one digit. It's like 0.6 or 0.5, and they don't go like 0.61 or 0.69. So I don't know if it was real close to 5 or real close to 6, the end of 6. So I don't know if it's a little tiny rise or a whole 10th rise. What else?
Ken, give the guys, because not everybody may know, give them a of your disease experience and how long you've been at 0.5.
Oh, well, I started in February of 2017 with a real high PSA in the 500s. I went on ADT. actually Casodex first and then Lupron within the first 30 days, and it took it from the top, like the high 500s to 200. Then I went from there to chemo, which took it down to about 27 after 6 rounds of docetaxel. From there I went to radiation, and during the time between the chemo and the radiation, it went from 27 to 9. Then after radiation, it stepped from 0.6 to 0.5, radiation of the prostate bed and prostate instead of doing a radical prostatectomy. It's been over the last maybe 7 months. It's been, at 0.5. And then, of course, this is the month that it had a little rise.
So the question for those of you on the call who have had a bunch of treatment and are dealing with the long-term management of metastatic disease, which unfortunately is Ken's case, how many, or has anybody had experience with the PSA jumping around? How have you dealt with it? Even small rises? Anybody want to respond to that?
I would just track it every month. I mean, if you're getting your PSA checked every month, just make a graph, make a chart, and watch it. Because going from 0.5 to 0.6 isn't significant in and of itself, but
Right.
But if you track it over several months, for each month, make a graph and just see how quickly it starts going up or levels out or whatever. I wouldn't get too concerned yet. And have you ever had one of the high tech scans yet, like a PSMA PET CT or anything like that yet, Ken?
No, I have not. I mean, about in February, I had, scans at MD Anderson, and I'm honestly not sure what kind of scan, MRI or bone scan that they did. I don't really know the terminology that well, so I can honestly say I don't know. I know the track is something that I do, and I have a graph, and because I know I'm in for the long haul as far as managing the disease. So I have, every stage of treatment, when I started, when I stopped, the PSA reading, my T levels, which unfortunately my doctor here locally doesn't think measuring your testosterone is important on a monthly basis, which they kind of have every time I go see her about it. But hopefully she'll get that. I think it's important, and she'll just order it every time I go in for blood work.
Right. Well, I watched mine go, over 4 or 5 month period from 0.1 all the way up to just under 1. And, so I knew something was going on. I watched it and I could tell how fast it was doubling for me, like 6 or 7 weeks or so. So I knew something was on the move, but it took, I didn't panic about it. And you can get a really good scan once your PSA gets up. To, I mean, even now, but I'd wait a little while, and that would, if it was me, I would wait a little while and just watch the trend.
Yeah, Paul, it's 4-week cycles. I should wait 8 weeks to see for sure. One, to see whether or not it was just a weird reading this month, and maybe, the colonoscopy had something to do with it. Maybe it was just the lab had an issue that day, and maybe I'm running real close to 6 at 0.59, and I just don't get the other digits to know that I'm that close to 6. So maybe there's not that much difference between my 5 and my 6 number.
Yeah.
Just a couple of things I just want to mention for Peter's benefit. One is that Ken does have significant mets in his bones, so it's not as if the mets cannot be seen. I mean, it's not as one of these situations where, like yours, where you see your PSA rising, but you're not sure where the disease might be. I mean, Ken's disease can be seen, and it can be seen in the lymph nodes as well. So
Okay.
I'm not sure to what extent something like an Actinium or a PSMA based scan would be necessary. Ken and I talked about how often he gets scanned, and right now Ken's on a 12 to 18 month cycle with MD Anderson, and that's something else. I'm wondering if anybody else wants to sort of talk about that. Because to me, that's, I mean, I know some of you are on shorter cycles than that.
What do you mean by a cycle, Rick?
How frequently Ken gets scanned?
Oh, okay.
Yeah, that was a comment from Paul when I first met with him about, and I know you guys have talked about it in the past, about the stuff that they use to actually do the scans, and he didn't want to introduce, he wanted to try to keep it out of my system as long as he could, because he knew I was going to be doing this for the long haul. But I don't really know. He just mentioned it kind of in our very first meeting, because I went back and listened to his chat, because I recorded it when I went in and sat with him the first time. And we talked about scans, but he never really gave me like how frequent one would go for scans. But he did make a comment that the medium that they use to get your bones to light up, you know, can be cumulative.
Right. Dennis, how often do you get scanned?
Right now it's once a year. I think that's because, you know, nothing's changing with my PSA. If PSA would start to go up, then I think we might do another acumen scale scan. Because it's staying still, it's going to be a standard bone scan and CT, I believe. PET scan and bone scan, yeah.
And Jay Curran, how often are you getting scanned?
I think it's once a year, but I've had other problems, so just coincidentally, there have been other maybe one other scan in between.
Okay. And the other thing that I wanted to raise that that posed a question in my mind is this issue about your oncologists not being willing to test your testosterone. And I've had discussions with people. I mean, I remember talking to Phil Febo one time at length about this. But for me, I don't understand how they can rule out that the LHRH drug just isn't doing its job and isn't working properly if they don't test your testosterone. Has anybody else considered that issue and had any discussions with their oncologists about it?
Ken, are you just on first line ADT or second line also?
No, just first line Lupron, that's it. That's all I take is Lupron. Yeah. So
yeah, in that case, I would agree with Rick that it should be tested at least occasionally, because I know of several cases of guys on Lupron that were not well controlled at all in their testosterone levels, and they would rise over 50. So you never know.
I mean, every time I go in and ask for, well, I have a lab schedule, I'll go in and like maybe once, she never ever puts on the order. I usually have to talk to the girls and say, hey, no, I want my testosterone checked as well. And they'll usually pull an extra tube. But in some cases, they have to call around and look for this doctor to get the approval. And it's like, I have to wait there then an hour and a half until they find her. So why they can't just put a standard request, you know, my labs include testosterone, I don't know why they can't do that.
They can. The answer is they can. They can. Just lean on your doctor and ask for it.
Just need to be more pushy, I guess. I will, though. I will say, because I have a meeting scheduled with her coming up. It was scheduled for the 22nd, but I'm going to move it, I'd say, to the 12th, which she's probably not going to like, but that's what I'm going to do.
Yeah, I think that's a great idea, Ken. I'm really pleased you're doing it. Would you like to share with the guys why you need to move it?
I can, of course, if you'd like. I decided to go on a little outing or a walkabout into Australia for 20 days. So, and it happens that I leave on the 23rd.
That's awesome. How long is that?
It's a 20-day trip, but I'm hitting like 5 major spots in 20 days, starting in Sydney, then Cairns, gonna scuba dive the reef. Then I'm going to go to Perth and go down to the Margaret River area. And then I'm going to fly into Melbourne and see someone that Rick put me together with about a year and a half ago.
So we should talk a little more about that, because I really want to give kudos to Ken. Ken has supported a guy called Cam Upton, who I think he might have been on the call once, but he's a young guy. He's 43 or 44, is that right?
Yeah, 44 this year.
44 this year. And he got diagnosed with metastasized prostate cancer, and I can't remember how he came to us originally or came to me, but I hooked him into a couple of people, Rob, God rest his soul, and also to Ken. And Ken has been just amazing, and they've had almost daily contact on Skype or however they communicate, I don't know. And I had a feeling up front that it might result in a trip to Australia, and it is. So Ken's been practicing standing on his head for the last 6 months, and he's ready to go.
Well, you're absolutely right, Ken. You're absolutely right. I just got, and I don't know if you guys heard it when I was chatting, but Cameron just sent me a message. So it's pretty much every other night. And I must admit, it goes both ways because I get as much as I give. So,
okay.
But it is definitely easier for me being single to travel versus him as wife and 3 boys.
Right. I think his boys are about the same age as Bill's kids, I think, aren't they? Bill's kids, how old are they?
Yeah, they'll shortly be 11 and 12, so.
Yours are 11 and 12. And how old are Cam's kids?
5, 7, and 11.
5, 7, and 11. Okay. Anyway, thank you. I mean, with everything else going on, I think to give you the type of support to Cam that you've offered is just amazing, and more power to you. And we all hope you have a wonderful trip. And
hopefully this next will be ballistic.
Well, get that test done earlier, as I suggested, and then if there's any issues, we can try and talk them out before you get on that plane. How are you flying there? From Phoenix to where?
Oh, LA and then on.
Okay. Okay. And how long is the flight from LA to Sydney?
That's a good question. I honestly don't know. I think it's probably 18 hours or 20 hours, or honestly, I don't know.
Okay. All right. Well, keep us posted, Ken. And I think Peter's advice is good. You know, I think I do think you need to check to make sure that your testosterone level is well maintained, and that you are at castrate levels. I think that's really important. I think that this small, I mean, I have known guys, and there are probably guys on this call who have tested again within a very short period of time just to make sure that there wasn't an error in the test. But other than that, testing on a monthly basis, as we discussed, makes a heck of a lot more sense than on a 3-monthly basis. And so I think, you know, it's good to keep a close eye on it, and hopefully it's going to stabilize right around. I mean, you know, like you say, they're not doing to 3 digits, and that's another thing that you could ask is, could they do an ultra-sensitive test for you, at least, you know, whilst your PSA is in less than 1, and it, you know, it might be helpful for you, and you can request it. Has anybody got any words of advice for Ken on how to insist on the type of test that you want from your oncologist? Peter, maybe?
Yeah, well, I'm in a different situation because I don't have a prostate. But I mean, you have a great oncologist, and I would think he'd be very amenable to having a ultrasensitive test once in a while too. Particularly, you can graph it much easier when you're under 1 in terms of PSA. You can keep an eye on it much easier that way. And since trends earlier.
Well, I'm going to ask for the ultrasensitive. Hopefully the lab that I go to, Sonoran Quest, has the ability to produce such a result. But I must admit, I'm confident in Paul Korn, who's at MD Anderson, but Paul kind of gives directions to the other oncologists, the ones that are here locally in Phoenix that I go to and see on a regular basis. So here locally is the one that isn't so keen on testing for testosterone. And you know, the bottom line is I like her, but every now and then I think, you know, maybe I should look for someone else.
Well, what you do is what I do is when you see Paul Korn, or if you have an ability to fax or email him or something, get a standing order from him. That's what I do. My oncologist is in California. I get my PSA tested in Hawaii every month or every 6 weeks now, and I have a standing order that I take to the lab. And it spells out what I can get, what the order is. And if it's testosterone, PSA only, that's what they'll test for. And I have no problem getting my oncologist to give me that standing order. So I don't hassle with the lab when I go. They just have it on file and they know what the procedure is.
Okay, I'll do my best to get that done.
Dennis, how does your guy down here in Tucson coordinate with Singh at Mayo in Phoenix?
Well, fortunately, both docs are mutual acquaintances. They're actually good friends. So they talk to each other frequently, and sometimes I'll get a call from one, sometimes I get a call from the other. And they tell me I just talked to so-and-so, the other doctor. So that's been working out for me. I haven't had any problem getting anything that I wanted tested.
Okay. Well, I did suggest to Ken that if he wants to look around and he can switch his insurance before too long, then a local oncologist in Phoenix, a good choice would be Dr. Singh. I know you like him a lot, right?
Yes, I do. You know, another option, my local doc at one time wanted to put me on a 3-month blood work. And I looked at the literature from the manufacturer of the Zytiga, and I found an error that I shouldn't be going more than 2 months. So we moved it back to I told him that, and he just, oh, okay. So we went back to a 2-month schedule for blood work.
Ken, when are you eligible for Medicare?
You know, I found out today, it looks like mid-2019. So maybe August, either July or August 2019. But that more complicated than just that, Rick, because part of it has to do with me still working and that I make money, and I can't. And the only way they're going to actually start that program is if I stop working or if I don't make $1,080 a month or something.
No. There's two separate items. It's important to distinguish them, Ken. The first is payments, and that's really what you were talking about, your disability payments. That's not why you want your SSDI. The reason you want your SSDI is because you're eligible for Medicare. And that has no income issues surrounding it. So 28 months after your date of disability, whatever that date,
5 months and 24 months.
Sorry?
Everyone, I've talked to, and I went back through my notes, and then I called the Social Security Administration today. Stayed online. I stayed online a long time, but they said it was 5 months from the start date or when cancer was found. You have to wait 5 months, and then there's 24 months after that before you're eligible for SSDI or the insurance.
For the Medicare, you're eligible for your payments 12 months.
There's two things, and you said there were two things. The girl that I talked to, she sounded like she was knowledgeable. Right. She said only two conditions that allow you to get, Medicare early. And that is some cancer like retina cancer or something, and being 65. So I don't know that she's correct.
She's not correct. She's not correct because you are eligible for Medicare 20. I said 28 months. It's 29 months. I'm off a month, excuse me, but it's 5 months plus 24 is 29 months. So 29 months after your date of disability, you're eligible for Medicare. That is a completely separate discussion to when you're eligible to get payments.
Okay.
When you're eligible to get payments is, I believe, it's 12 months after your date of disability is when you're eligible. But then you have to not be earning enough money or you're restricted on what you can earn elsewhere. But for you, the reason you want to be, your eligibility is going to make your insurance much easier for you and much, much cheaper.
No, and I greatly appreciate it, as you're well aware.
So what I would suggest, you need to clarify that. Find out when your date of disability is, because that's an established date. Now you can argue that date. If you think that they didn't backdate it enough, you can go in and you can ask them to change it.
Oh, I've already got that.
Sorry?
I do have that date, and it's documented based on the time I got my pathology from,
Okay.
So it's like the 15th. That has already been the Social Security Administration, because I had put that in as soon as you and I discussed it in the very beginning.
Right, excellent.
I called and got that date logged in, and they understand. I'd have to get someone that's knowledgeable in regards to just Medicare.
Yeah. So what you hold on a minute, and I'll come to you, Peter. What you need to do is get somebody to go through with you, and I think you're going to find that you're eligible for Medicare 29 months after that date, which might be less than a year from now. And I know this because I was in that situation, and I got my Medicare at age 58, I think, is when I became eligible for Medicare. And that's got nothing to do with whether they make you payments or not.
Okay.
At least as I understand it. Now, they did make me payments and they did deduct something, but I don't think, but you don't have to take the payments. You can refuse the payments. Anybody else want to say anything about that?
Yeah, I went through this with my tamales for several years, and because he was 57 or something when I met him, 56, and he got his disability payments. He was on whatever it is, Social Security, SSDI or whatever. And he got that, but he had to wait for Medicare, or I can't remember. It was something like 28 months or something. But it was dated from his last day of employment when he for the county, when he could no longer work, and he was on it, and he quit the county. So it was a crazy thing because he had insurance. He was on some COBRA plan or something. County, his insurance was ongoing. He had to pay out of pocket for it or something. But he had to do that until his Medicare kicked in, and they wouldn't do it until so many months after his last day of work.
That's kind of the
I
information.
remember because we went back and forth to all these offices constantly every month because he was sweating it all the time of well, whether he's going to be covered for this or that or the other thing.
Right. Well, I'll either go down here locally where they have an office and sit down and chat with someone there. And I thought the girl understood exactly what I was asking, but maybe not. And she did make a comment that it's based on the day you quit work. And I told her, I still work. So if it's connected to work, then the date hasn't started. But then she looked through the notes from my earlier call, which had to do with Rick's statement, hey, get on this right away as soon as you get diagnosed, because there's, a 28-month waiting or 29-month waiting period. So I did that. So at least she was able to go back and look and see that I put in the application, but I did in fact withdraw the application to go whatever they wanted me to tell them I wasn't working, wasn't making any money, blah, blah. And so I started the ball and then I pulled it out, started. And at least she saw that, so she said she could use it as a start date. It's not really my start date because my start date, based on her last communication with me, the start date for the 29 months was the date that I got notified that I have stage 4 prostate cancer. That had nothing to do with work, and maybe that's the two areas where she's getting them confused as well. She's mixing, hey, you've got to stop work with, hey, you have to wait 29 months based on your data notification that you're not capable of working or whatever. SSDI.
Yeah, I mean, I could definitely be wrong. It certainly wouldn't be the first time. But my understanding was that actually taking the payments is a separate issue from being eligible for Medicare. The other thing that you might want to do is talk to get a consult with a Social Security lawyer, because they'll be able to clear it up for you in very quickly. You could probably do an hour, a half hour or an hour consult. The thing is, they're fairly few and far between, so you sort of have to dig around, but there's bound to be some Social Security lawyers in Phoenix.
I think that's a great idea.
But from your standpoint, you have a huge saving in your medical insurance.
Right. There's no $4,000 a year.
Yeah, I know it's a lot of money. So anyway, see how you do and keep us posted. And if I'm wrong, please let me know. But I did think the two things were not tight. You could separate your eligibility for Medicare from actually receiving the payments.
Okay, I'll let you know 100%.
Thanks. Thank you. Okay. So let's move along to Dan and May.
Hi, Rick. Thank you for letting me participate. Let me give you a perspective. As you know, I was on chemo. I went through 4 sessions. I was going to take a 5th one on last week, but because after 4 sessions, the PSA really didn't drop at all. It has been kind of going up. I went for CT scans on the 18th of this month, and yesterday I took some MRI scans, and the thought was because docetaxel is not working, the nurse practitioner who was substituting for Argowal, who was on vacation, said they may contemplate the chemo combination of
Paclitaxel
and carboplatin. So that
Right.
combination. I'm scheduled to see him in shortly, but that's what we're at right now. PSA on the last week was 374, so was still kind of hot, relatively high.
Yeah. How do you feel?
Okay, I've had based on the CT scans, there was a pronounced mets on the femurs, both femurs, left and right, as well as the right hip, where I was experiencing severe pain. So I'm taking ibuprofen as well as some hydrocodone to alleviate some of the pain as needed. But I'm sometimes I feel very fatigued. Sometimes I'm okay, but lately I haven't been feeling too good. Otherwise, just very tired.
And what about the comparison of this set of CTs and MRIs to the last lot? Is it more, less, or about the same?
I'm trying to follow.
I'll explain. The last set was at the beginning of May. Chemo was started on July 2nd, and his PSA had been doubling before he started chemo, but after chemo, it pretty much was stable for the first three times, and then this last time, the last 2 times it just went up, but not by much though. It's we're looking at about maybe 10 or 15% each time that it did go up. It wasn't doubling like it was before chemo. So we actually went in last Tuesday, the 25th, thinking that he was going to go ahead with chemo since Dr. Agarwal wasn't around to change the treatment. But Bridget, the nurse practitioner, says, I don't think we should continue the docetaxel, and so just didn't do it. And we don't know what's going on right now. She wanted an MRI because Dan expressed some kind of, his pain. And so she said, well, we should just do MRIs of the spine and see what's happening in there, just to make sure, is what she said. So we had it done on Sunday, and she called us last Friday wondering when we're going to see the radiation oncologist. And we said, well, nobody has called us. The person who is doing it, Paul Menzel, I think last Friday was his last day with UCSF.
Okay, let me interrupt you, May. How did his scan? How did the scans that he just did compare to the scans in May?
Oh yeah, it increased lesions.
Okay.
It increased. Yeah,
Size and number.
Yeah. Well, it didn't say anything about size. It was just weird the way it gets read. Some people will measure the size on sometimes, and then others will say there's increased lesions. And this time it just said there was increased lesions.
And has anybody discussed spot radiation with you? I mean, it sounds like this came as a surprise.
No. Bridget Bridget says to go ahead and do it. If you're in that much pain, then you should just go ahead and do it. And so she had, requested that radiation call us. They have to assign somebody to him because Dr. Menzel is gone now. But nobody has called. I just made a call and I left a message today to see if somebody could hurry up and call. I think I requested Dr. Felix Fang, but who knows if he's going to call because he's very busy.
Yeah, Feng is great, but there's a bunch of them. Joe Shu is really good, and Joe Shu, Felix Feng, Alex Gottschalk, Mac Roach. There's a bunch of them that are experienced. I guess there are a couple of things that concern me. I'm always worried about taking treatment decisions on the advice of a nurse practitioner. And, so in a sense, I think it's good that she's deferring the cabazitaxel and carboplatin conversation until Agarwal is available. Spot radiation is a little bit different because it's palliative, and if you're in pain, it's certainly a solution. Is it your hip that's painful, Dan, or is it the femur?
Mainly the right hip, but the femurs have been bothersome at times.
Yeah. Well, I'm going to turn it over to the guys, especially. I don't know if there's anybody on this call that's had spot radiation or not, but we'll find out momentarily. I do want to make a comment on the cabazitaxel and the carboplatin, though, because we've known people that have been on that protocol, and there's two schools of thought on that, and I think that you've got to dig down, because I don't know who's correct, but you've got to ask these questions. There's one school of thought that thinks you can combine them, and you can do both at the same time. And there's another school of thought that says you should not combine them because you don't get the benefit of either one when you take the two together. So you should do either the carboplatin or the cabazitaxel, the Jevtana. So I think what I would probably, if it were me, what I'd be asking Dr. Agarwal is for evidence as to which way he recommends and why. So those are my two inputs. I think it was Eric, Eric Bookbinder, who brought this to our attention and said that you should do one or the other. So, that's, I think other people have mentioned it too, but anyway. So let me. Jim Harrington. Yeah, it could have been Jim Harrington. Yep. Yeah, that's good memory.
Rick, my concern is that there's a lutetium trial that's coming up at UCSF, and somebody had mentioned to me that usually to get on these trials, you could only have one type of chemo. If you have more than one, you could be disqualified. That's what my concern was.
That's a really good point. Well, I think the way you start is I would ask for I'd ask for the trial protocol. I can look for you later. There is actually there's a website. There's a UCSF website. I'll take a look in a second. Len,
Well, well, actually, I think we're going to try and make an appointment with Dr. Agarwal because he is the principal investigator for this upcoming trial.
for the lutetium trial?
Yes, and
Okay.
so I think Bridget sort of talked with him while he was out of the country last week about this,
Okay.
and because she was trying to figure out how soon it was going to be available, and I think he did get back to her and says he thinks it may be pretty soon, like towards the end of this year, with maybe a couple of months. I'm not sure, but it sounded like it's coming up soon. It's going to happen soon.
Well, I think that I think it would be a great idea. I mean, I know that talking to Almeida at PCRI, he's of the opinion that the earlier you do the lutetium, the better it is. And even if you do it pre-chemo. So I think you've got to really, you're really onto something there. And you don't want to exclude Dan by taking a different chemo. And clearly Agarwal is going to be able to tell you. I mean, a couple of things with that lutetium trial that I do know, or with lutetium, I should say, that I do know, is that, first of all, it seems to have a flare. So a couple of people that I know that have been on it, their PSA has gotten higher before it's gotten lower. Seems to take about 4 to 6 weeks to kick in. And I just want to tell you that up front. It's totally anecdotal. It's based on 2 people that I know have used it. And then it can have a dramatic effect. So because if you were to do it, just because it didn't work right away, doesn't mean it's not working. So that's the one thing. And the other thing, like I say, is that the earlier you do it, the better you are. Because I've seen 2 people do it at a point where they're just not strong enough to keep going with it. And that doesn't sound like the situation with Dan right now. Let me throw it open to anybody else that would like to talk to you about your situation. Starting with maybe Len or Peter.
About the only thing I could comment on, Rick, is I remember lutetium trials were discussed at PCRI, and the trial criteria, as I recall, was that you had to have had at least 1 regimen of chemotherapy. I don't recall them saying that if you had more than 1, that would disqualify you.
Okay.
I would think that Dan would still be eligible.
Okay. Okay. And anyone else like to say anything or have any input for Dan?
Dan, I met you before in San Francisco. I'm sorry you're going through this, but I know you've got the best care possible up there, and I think you should consult with Agarwal and have him guide you through the next steps for sure.
Yeah. Okay.
You're in good hands. You're in a difficult situation now. My heart goes out to you.
Thank you.
Trying to figure out the next treatment
Yeah.
with you.
Okay.
Can I just ask if anybody knows about Xofigo? Because I asked whether or not that was possible, but again, I think the nurse practitioner has said that if he's going to do the radiation, then it's not a good idea to have Xofigo later on, because it all depends on whether or not he's healthy enough for Xofigo if after he gets radiated. And so that was another concern whether or not
Mm-hmm.
to go through with the radiation, if it's going to prevent him from having sulfigos, because she says they both go into the bone marrow, and so if the radiation destroys part of it, then it wouldn't be strong enough to take the sulfigo.
Well, I mean, the first thing I would say to you is that if it were me, I'd much rather be doing the lutetium than the Xofigo, because the lutetium is much more targeted than the Xofigo is. Xofigo is the radium-223 is attracted to calcium, whereas the lutetium is attracted to cells that express prostate-specific membrane antigen. So, so they're a lot more focused. So, and also, I'm pretty certain that doing Xofigo would exclude you from a lutetium trial. So, I would. I mean, they're kind of similar. They're both what are called radionuclides, but they work in a different way. And so, if you could find a lutetium trial to do, you'd be a lot better off than doing Xofigo. So that would be my input on the Xofigo. Now, the question as to what you might do whilst you are waiting for the lutetium trial is more difficult, and I think that's where you got to rely on Agarwal. As Peter says, he's a good doc, and you have a good relationship with him. You've been with him a long time. The one thing I wanted to ask Dan was, when was the last time they sequenced your tumor, Dan? I know you had it done. If I remember, they didn't find anything. Isn't that right?
Right.
Yeah, that was just only a few months ago.
Okay.
Is that the Garden 360?
No, there was the bone biopsy.
Oh, bone biopsy. Yeah. Okay.
Right. So the bone biopsy didn't turn anything up?
No, and Dr. Agarwal says to do germline next, and so I don't know what's holding it up right now. I think Dan.
Well, yeah. I mean, the germline. Look, the germline costs you $150. You can do. You don't need them to do it.
Oh.
But so you can do a germline through color, and if they don't, and Peter, how long did it take you to do germline through UCSF?
I mean, to get the results or to do it?
To do it. I mean, how did you go? How did you go about doing it at UC? How can you navigate Dan and May to get a germline test at UCSF?
Yeah, you call up and make an appointment for a genetic counselor. They have a genetic counseling group there. I can't remember whether it was Mount Zion. I think it was at Mount Zion. I can't remember exactly. But I sat down. I had an appointment. I had to come up with a chart of all the cancer history in my family on my mother's side, my father's side, and so forth. And I didn't have extensive cancer history, but I had enough because I had a dad that died of aggressive prostate. Anything with breast cancer, anything with colorectal cancer, any cancer history in your family, you kind of have to write down and use that to let you know that you're a candidate. I think I had to pay $90 out of pocket. This is a couple of years ago. And then she just took a mouth swab right in the office there. I mean, she's not an MD. She just has this kit. She takes a mouth swab, sends it into, at that time it was Ambry Genetics. They might not use that anymore. And I think 2 or 3 weeks later, I got the results.
Sounds doable enough.
Yeah, it's pretty
What did you say, Peter? I missed that.
It's very simple. It's a very simple procedure. But they do ask that you have a genetic counselor go over this stuff with you.
Len, do you just want to tell Dan and Mayor on the telephone? Do you want to tell them what you just put in the chat window?
Oh, sorry, I didn't realize you were on the phone. Yeah, so you can't see this in the chat window, but I just extracted something from a summary document I made of the lectures at the PCRI conference in LA about a month ago. And so this is what I put there. Dr. Kwan from Mayo Clinic stated that the eligibility requirements for lutetium phase 3 trial are the following: must have failed at least one taxane regimen, which I believe you did, at least one second generation ADT, which would be Zytiga or enzalutamide, and you must have a rising PSA and visible lesions on radiographic scans. So I believe that means you qualify.
But what trial was that for? Is that for a trial that he's running at Mayo? Or?
Yeah, but I don't believe it's only at Mayo. Let me go. I have to go back to my notes and see if I indicated the name of the trial. Oh yeah, it was called Vision, VISION, Vision trial, phase 3 trial.
Okay. My guess is that the trial qualifications, even if they're not one and the same trial, are going to be similar across the board. I mean, I know that Almeida's running a trial out of Phoenix right now that has no significant expense associated with it. And that one you can certainly find. I've got a link to that trial. But it would mean you having to go to Phoenix for the treatments. He's getting ready to start another phase, and it's a question, of course, of who he would select to go into that phase. I mean, if you could do it at UCSF, it would clearly be the best thing for you. So I do think that starting a discussion with Agarwal is good. I cannot see. I was looking at the UCSF site for their trials, and I don't see anything indicated with starting up with lutetium, but that doesn't mean much because they're not great at keeping their website up to date. The place you would see it would be on clinicaltrials.gov. You know, if you went to clinicaltrials.gov, you would see if there's anything open. Does anybody else have any input on the carboplatin cabazitaxel issue? So I think the two people we know that have been through that, one is Jim, who sadly is no longer around. The other is Eric. Eric, by the way, is doing okay, and he's doing pembrolizumab right now, Keytruda, and he seems to be pretty stable on Keytruda. Jake reached out to him, and he wrote to us during the week. And there is a Keytruda trial at UCSF right now. So that's something else you might want to talk to Agarwal about. I mean, did they give you a copy of your sequencing results?
No, that doesn't sound familiar. No,
Well,
I haven't gotten anything like that at all.
Well, you may have to ask for them, but he should be, if he gives you a copy, we can.
He gave us the copy of the first one, the liquid biopsy, but the
Right.
second, I'm not sure.
The bone biopsy. Did they do the bone biopsy at UCSF or did they send it
Yes,
out?
they did. They did.
Yeah.
I think it was
So,
during the month of May.
yeah. So there's a pretty big report, I believe, that comes with that, because one of the questions we'd like to know is what your MSI number was, that microsatellite instability, because that might be an indicator whether you'd be a candidate for Keytruda or not.
He did talk to us about it because Dr. Abrams asked him whether or not Dan would qualify for the Keytruda, and Dr. Agarwal says from the bone biopsy results, he says no, he does not.
He doesn't think so, huh?
Yeah.
Okay. Well, I think that if Dan could get into a lutetium trial on a timely basis, if it were my choice, that's what I would be doing, and park the cabazitaxel and the carboplatin for a while.
Okay.
And if it means that the docetaxel, you keep doing the docetaxel to hold you, because while May brings up a really good point, and this is what I would have probably said to Bridget. The fact is that whilst I'm on the docetaxel, or whilst Dan's on the docetaxel, his PSA isn't doubling anymore. It's gone down to going up maybe 10-15% a time. So
also, pain. The pain was he didn't have pain in between.
okay, so those points are really good. So if there's a lutetium trial coming up, and but it's just not ready quite yet, but Rahul thinks he can get you into it, then maybe the thing to do is to talk to him about staying on the docetaxel until you're ready.
Yeah, sounds good.
I mean, even though you're failing the docetaxel in the sense that your PSA is going up, but it's doing something. When are you seeing Agarwal?
We don't really have our next appointment with him. The next appointment really is October 15th, when he's due for, that should have been his last chemo. But we kept that appointment. Bridget says to keep it just in case Dr. Agarwal thinks he should go back to chemo. So we haven't canceled it. So I assume, unless we can see him earlier, the next one will be October 15th.
Okay. Well, see if you can get an appointment with him as soon as he's back, and if not, October 15th. But maybe you can get in to see him sooner.
Okay.
You have to push for it, May. You know that.
I know. I thought he was going to call us today, but we haven't heard from him. Usually he's really good about calling.
Okay. Well, if he's been away, he's probably slammed, so it takes him 2 or 3 days especially if he's been out of the country. Anybody before we go to Jay Curran? Anybody else want to say anything? Jay, do you have any thoughts for Dan and May on the management of Dan's situation?
Well, I was going to say I had the UCSF 500 test, and at first they thought it wasn't going to help too much. But Dr. Agarwal did say that I would be a candidate for Keytruda. So I don't know if that was any of the tests that you had, Dan, or not. It sounds like no.
No, I think
it was.
I think it was.
Yeah.
Okay.
That's what the bone biopsy was. That was the UCSF 500 test, Jay.
Oh, okay.
Okay. Anybody else?
Hey, Rick, I'm just looking at a publication from 2016 saying that adding carboplatin to cabazitaxel improves progression-free survival in aggressive variant castrate-resistant prostate
Oh,
cancer,
wow. Okay.
for what that's worth.
No, it's worth a lot. I mean, that's, I think that Jake's right. I think it might have been Jim Harrington, God rest his soul, who was the guy that said you shouldn't mix them up. Anybody else have any recollections on that?
Well, Rick, he was taking the two of them together. But it doesn't seem to be doing any, didn't seem to have done much good for him. Jim did actually take the two together, if I remember correctly.
Yeah, I'm just looking at his situation. Yeah, he did take the two of them together. So then maybe it was Eric that said you have to split them up. Well, you can reach out to Eric, Dan, if you want.
Okay.
But he's seeing Agarwal as well. So, my recommendation is to talk to Agarwal and ask him what his feelings on whether you should mix them or whether you should take them one at a time.
Okay.
I mean, we're not docs. We don't know. I mean, that's good research that Len just came up with, but Agarwal's going to know. But I do think it's a question you should ask him. And, get that appointment with him pretty quickly, as soon as you can, in fact.
Okay.
Okay, and then come back and tell us, and, we'll give you some ideas for the next round. But if you could get onto a lutetium trial, that would be dynamite.
Okay. We'll push
Yeah. Okay. Jay Curran.
Okay, I saw Dr. Agarwal at UCSF on 18th September, and he offered me Keytruda, and my PSA had jumped in the last month from 13 to 32, and so in the meantime, I've found a couple of studies, and I'm wondering if they're worthwhile or not. And one of them you mentioned, it's called switch from abiraterone plus prednisone to abiraterone plus dexamethasone for asymptomatic PSA progression in patients with metastatic castrate resistance. So that's one. And the other one, I'm confused. Did you mention, Rick, radium 225? Because I have another study that's acetate, not acetate, but actinium 225. Is that the same thing or no?
No, actinium 225 is not the same as radium 223.
Oh, okay.
So the actinium is also PSMA sensitized.
Okay. All right.
And Mike Scott just reported on an actinium trial, but I haven't read what he wrote yet. But let me ask you something.
Yeah.
What you're looking at these trials? How does that relate to the Keytruda? You're looking at these as alternatives to the Keytruda?
Possibly, but I think I pretty much made my mind up to go on the Keytruda.
And what about the lutetium trial? Because you've been big on lutetium for a long time.
Yeah, I am. But
when you first started talking about it, I certainly was not in your court, because my understanding was wait, but I've really switched around on that from talking to certain people and also seeing people wait too long, and so one discussion with Agarwal might be, what about the lutetium trial, the one that, Dan might be considering?
Yeah, I've talked to him about it, but he said Keytruda. Now, there's different kinds of lutetium trials that are going on. Some of them have an R2 at the end, and some of them have 617 at the end.
Yeah.
And so there are more than one.
Right. So let me explain what that is. So those numbers at the end are the contrast agent or the tracer agent that is carrying the lutetium to the cell. So the lutetium is the radioactive part, and then it has to be carried to the cell. And so the original lutetium trials were all done with this 617. But now there are a couple of other agents that they're trying. There's 3 that I'm aware of. I forget the number of one of them, but one of them is the R2, which is the one that Almeida is testing in Phoenix. Are you aware of them testing more than one type of tracer at UCSF or not?
He indicated that they're going to be doing more than one.
Okay, that would make sense, because if you do a head-to-head with different tracer agents, then you get to figure out which one works the best. I would probably drill down with him and find out why he likes the idea of Keytruda better than he likes the idea of lutetium, and be comfortable in your own mind that that is the best. It may be a timing issue that the Keytruda trial is ready and open right now, but the lutetium trial isn't open. It could be as simple as that. Could be that you, unlike Dan, have the right genetic features for the Keytruda trial, and so that you are eligible for it right now. There's different things, but I would want to be satisfied in my own mind that I wasn't just being pushed into one of these trials if there were a choice of trials, and they're very, very different. The way in which they control the disease are totally different. The radionuclide trial and the immunotherapy trial, the Keytruda trial, which, by the way, is what the guy got the Nobel Prize for this morning.
Really? Okay.
Yeah, the Japanese guy.
Okay.
The Keytruda comes out of not Jim Allison, but the Japanese guy who got it with Jim Allison.
I have the or whatever. I'm eligible. I think the reason he's saying Keytruda is that I have CDK12, which the idea is that only about 7% of the people with prostate cancer would have that. Maybe they would have a 40% chance of that working. But I guess if it works really well. If it doesn't work, it doesn't work.
Okay. Well, all I'm saying is just be sure. I'm looking at the trial right now, pembrolizumab in metastatic castrate-resistant prostate cancer with or without DNA damage repair defects. So, this must be the trial. And Larry Fong is the principal investigator on that trial. Started in February of 2018. Look, it's a great way to go. I just want to be sure that you know, it doesn't rule you out of the lutetium going forward. And I mean, the one thing with the lutetium is to do it early enough so that you can't finish the treatment. At the same time, Keytruda's great, but I mean, and as I said before, it seems to be doing a good job for Eric right now. So, you know, they're both good alternatives. I just want to be sure you weigh them up in your own mind.
One question I wanted to find out, and maybe Eric's the one that would know, how soon he started to get results. 3 months, 6 months?
Oh, I think he probably, I mean, he's only been doing Keytruda for a couple of months at the most.
Okay, thank you.
And my guess is that he's on the same trial that they do on.
Now, Dr. Agro didn't mention anything about trials, but you know, maybe that's what was in the back of his mind.
I'm sure this is a trial that he wants to put you into.
Okay.
I bet dollars to donuts that he's talking to you about the trial at UCSF with the Keytruda, the pembrolizumab. So, you know, you need to talk to him a little bit about that. And
the way it's set up now is I'll have an appointment with him, and then an hour later they'll start Keytruda supposedly. But since he's been gone, maybe some of this, you know, will change.
Well, maybe then it isn't the trial, because you do have to sign the trial documents. But I would check with him.
Yeah, he said I did not have to sign any documents that all be done at their end.
Okay.
But anyway, so what do you know about Actinium, whatever that's called?
Actinium?
Yeah.
I'm just going to put for those who are online, I'm going to put the reference to the trial that at UCSF that I'm looking at. So, and it's other people can look at it. I don't know much about actinium. I know that it's being tested. I don't know if it's better or worse than lutetium. Anybody else know anything about actinium as a radioactive element?
I don't know much either, Rick.
I can just read the conclusions. It's a trial out of South Africa, and it's about 3 sentences. It said remission could be achieved with 225 AC PSMA 617 RLT in chemotherapy naive patients with advanced metastatic carcinoma. Remarkable therapeutic efficiency could be achieved with reduced toxicity to the salivary glands due to a strategy of de-escalation and on the second and third treatments, and they went further studies, of course. That's it.
I wonder, that might be the trial that Mike Scott was just reporting. Where was that published?
It was published in European Journal of Nuclear Medicine and Molecular Imaging.
Okay. Okay. So it could well be, I don't know, I can't look right now.
Sure.
But it might be the trial. Len, do you know if that was the trial that Mike Scott was referring to?
I don't even recall Mike Scott writing about actinium. How long ago was that?
Just very recently.
12 September was accepted for publication.
Yeah, I've got it here. I've got it. I've got it here. Let me just let me look.
if I'm not mistaken, I think I posted it on the Facebook page. And Jay mentioned the salivary glands. Apparently, it's one of the biggest side effects is dryness of mouth.
Yeah. Yeah, this is the one. This is the trial. This is the trial that he posted. So again, I can put the link. I can put the link in the chat window. And this is why I really encourage you guys, if you can join by online, it's to your advantage. Because you can see these links as we go. But yeah, it's a small study, 17 patients.
Okay.
And 15 of 17 had 50% regression of their metastasis. It's particularly good for patients that have not been pre-treated. And it was written up by Alan Edel, who some of you may have noticed has just, because I put it in one of my recent missives, has just joined our advisory board. So yeah, I can't tell you. I haven't looked at the study, but it's certainly that's certainly what it's about. But the thing is, it doesn't necessarily. It may not be pertinent in the sense that I don't know if there's an actinium study that's available to you.
Okay. And then the N is small.
Then what?
They didn't do it on very many people so far. So new.
No. I mean, it's a 17 patient study, but most of these lutetium studies are pretty small.
Yeah.
I should say radionuclide studies are kind of small. So I cannot tell you if one's better than the other, but I think, practically it's what's available to you as opposed to which is the better one. Because even if we said actinium was better for you, you've then got to find a place that you can do it.
Yeah. As far as adverse effects with Keytruda, I know of 2 bad ones, and I know of 1 good one. And the good one, the guy said he hardly even felt like he was on any treatment. His PSA went down, and that was it.
And what were the bad responses?
Well, one guy didn't kind of take care of himself very well. He went out and started to work hard right away after he got an infusion, first one, and his heart stopped a couple of times in the emergency room. They brought him back, and the other one had he had to drive about 400 miles after the first infusion, and he said it was terrible. And
I mean, some of these things are you got to wonder about the people. I mean, you don't do an infusion and then get in a car and drive 400 miles.
That's true. That's true.
The only side effect that Eric's complained of is nausea.
Okay.
But you have to take care of yourself when you do, especially some of these cutting edge treatments,
Yeah. I think they've been prescribing Keytruda for other cancers, so there may be some more experience with it.
Well, they have. I mean, they going back to when Trevor Doherty was alive. We got him Keytruda, but we got it for him too late in the disease cycle, and he had 1 infusion, but he just wasn't strong enough, and he died right after that. We were trying to get it for him for weeks.
Yeah, I remember that.
But yes, it has been prescribed for a while, and if you went onto some of these forums on Inspire, I'm sure you could, you could put it in for, what's it approved for? I think lung and melanoma. I'm not sure. I'd have to look. But, go onto the forums and put in the keyword pembrolizumab or Keytruda and see what people say about it.
Okay, I tried us too, but I didn't get too far. I'm all thumbs on the computer, but I'll do that.
Yeah, but us too is going to give you prostate cancer experience, which is very helpful. But there are other diseases that have got longer.
Okay.
But if you go ahead, Peter.
Yeah, Jay, I just want, Len brought this up in his PCRI summary, but I know my doctor, my oncologist down in California with prostate oncology specialist, they swabbed me about 6 months ago to test me in terms of how well I would tolerate Keytruda if down the line I'm a candidate for it. And the result came back that I probably would tolerate it. And I think Dr. Turner at PCRI mentioned that they're working with some kind of something who's developed this swab test to kind of pre-screen for tolerance to Keytruda. I don't know much more about it, and I don't know how many people are using it.
Was that compassionate oncology?
It's prostate oncology specialists.
Okay. Yeah, I did hear a whisper about that from another source, and then I couldn't track it down. Okay. Sounds like a good idea.
So, Peter, what you were saying is that they have developed this test that Turner was referencing at PCRI that can determine if people taking pembrolizumab would be susceptible to the autoimmune reaction or not?
The way it was described to me is how well I would tolerate the drug. As Jay said, he's heard 2 horror stories and 1 good report. I think that, it relates to how well, not about how effective it would be, but at least how well you would tolerate taking the drug.
Right. Well, I'd like to see that reference. That'd be very interesting.
I remember Turner did discuss that in his breakout meeting. And people asked him questions about it, but he didn't really explain what the test was. But he did say that that they do have a test. Thank you for bringing that up, Peter. I had forgotten about that. So
well, that's about all I have.
What I would suggest, Bob, is that you raise that also with Agarwal. Tell him that you're aware that that Turner down in Marina Del Rey, he'll know who that is doing a swab to test for toleration of Keytruda. Does he know anything about it? Is that something that you might be able to do with him with UCSF?
Sounds like a good idea.
Larry Fish, you joined us a little late and I didn't check in with you. Is there anything you would like to talk about today?
No. I just got in. We were on vacation in Mexico. We flew in, and I just joined in an hour ago. But thank you.
Did you have a good time?
Yeah, it was nice. It was near, Riviera Maya, our usual vacation.
Okay. Terrible thing. That's terrible for it to be the usual one, isn't it, eh? Okay. Peter, we have 10 minutes. They're yours.
Okay, I sent something to Lynn 5 minutes ago or so. I don't know how many of you received this. I got an email from Walt Darden with the Silicon Valley group, and this is the first time I've seen this. He sent me an article dealing with the potential for false positives with PSMA scans. I can't, it's be a little bit hard for me to summarize it, but essentially what it says is that some benign tissue from different organs and parts of the body can show up as indication that there might be lymph node metastasis when it really is just benign. And this is the first I've heard about it, and it's just a heads up. I think it's kind of new information. I'm not particularly worried about it myself, but it is something to mind and discuss with doctors. You know, particularly those that are reading the scans.
Peter, does this bear any relation to the fact that we know that prostate-specific membrane antigen shows up in other parts of the body other than the prostate, or in other cells in the body other than prostate cells?
Well, I'll read here. It says, however, past studies have noted that some benign tissues also show increased PSMA expression and could potentially be confused with lymph node metastasis. These tissues include parts of the kidney, bowels, salivary glands, and ganglia, the sympathetic trunk. Result, anyway, that's off.
Right. So we know, I mean, the one thing that I've heard about and we know about is that it's in the salivary glands.
Right.
And that's why you have this issue of dry mouth. And it's a known effect. In fact, Jay just referred to it. It's got a name. It's called xerostomia. Zero means dry and stomia means mouth. So I'm not really sure why they couldn't call it dry mouth. but they don't. They call it xerostomia. And there are a couple of strategies like reducing the dose subsequently that are supposed to make it better. But and there's no real explanation of why the heck prostate-specific membrane antigen shows up in your throat, but it does. I hadn't heard about it showing up in other places, but you know, if it does, then maybe it refers to lymph nodes in other parts of the body closer to those organs. I don't know. Don't know.
It's just a heads up that you know, that if you're using a PSMA test solely to diagnose prostate cancer or whatever, or where it's showing up, you got to be careful because you could set yourself up for misdiagnosis.
Right.
I perked up my ears because, you know, essentially that was the case for my own recurrence. I used the PSMA test, and it did light up a couple of lymph nodes, abdominal lymph nodes.
Right.
I don't think they were, you know, I'm pretty sure they were real. I did perk up my ears when I read this. That's all.
Okay, well, thank you for bringing it to our attention. Anything else for you, Peter?
No, I think that's it. I'm still doing well. Still tolerating Zytiga real well. A month and a half to go, and I'm kind of anxious to get off these drugs.
Okay.
And see how long a holiday I can have. Yeah. I'm tolerating them real well. And
Okay. How much time do we have? 5 minutes. Len, did you want to talk about the steroid, about the different steroids with Zytiga?
Well, I could, but it might be irrelevant if no one on the call, other than Peter, that is currently taking Zytiga.
Dennis is taking Zytiga.
I'm taking Zytiga and prednisone. Yep.
Right.
Oh, okay.
Anyone else? No, I don't think anyone else. But
I'm on the edge of maybe starting.
okay, go ahead. That Larry Fish pushes us over the edge.
Okay, well,
let's
hope you don't go over the edge, Larry. But for Dennis, there was a phase 2 study showing that patients who were beginning to fail prednisone plus Zytiga were switched to Zytiga plus dexamethasone. So it's a different steroid. And I don't have the exact numbers, but a lot of the patients who switched had significant declines in PSA. They were speculating that prednisone might be one of the reasons why patients stopped responding to Zytiga plus prednisone. So no one really knows why, but empirically, they did find that if you switch to dexamethasone, you can get more life out of Zytiga, basically, a longer run. So something to keep in mind, Dennis, if you find that it looks like you're starting to develop resistance to Zytiga and prednisone. Talk to your doctor about switching from prednisone to dexamethasone.
I will definitely keep that in mind. Thanks, Len.
Sure.
Hey, Dennis, that was worth the price of admission, wasn't it?
It was. That was worth staying on here for 2 hours.
Yeah, I'm gonna meet with Dr. Turner on the 16th, and I'll definitely bring this one up to him, make sure he's aware of it, and get his input on it, and get back to you with it.
Okay.
Just a quick question for Peter, Rick. Peter, so if you go on drug holiday and your PSA remains undetectable, are you then going to be postponing your proton therapy for those abdominal lymph nodes?
No, I'm going ahead with a proton beam therapy, and I'm going to get one more Lupron shot on the 16th, so everything will run out on about the 20th of November. So I'll kind of glide out from there. So I'm going ahead with the proton beam, and then I'll be off of treatment when I finish that.
Okay.
So.
Slipping into the Hawaiian sunset, correct, Peter?
Yes. I'm getting anxious to go home. Getting cold up here.
Uh-oh. Okay. All right, guys. Well, look at that. We finished right on 7 p.m. with a lot of information in today's group. I had a feeling it might be a good group with some good discussion. Thank you to everybody. And the next group will be next Tuesday, the 9th. Next Tuesday, the 9th. And I will be sending out, who knows what I'm going to come up with between now and then, but a couple of good things have certainly come up in discussion on the call. That's about it. Peter and Len, could you hold on a minute afterwards so we can just have a quick chat?
I can.
Good
night, all.
Thanks.
Good
Night.
Thank you very much. Good night, everybody.
Everybody, thanks, guys.
Night.
Good night. Good night.